Hi, and welcome to this short course on the prevention of mental illness. I'm your trainer. My name's Faith Price. I'm the Prevention Director at All Nations Health Center in Missoula, Montana. I am the chair of the Healthy Missoula Youth Prevention Coalition's Policy and Law Committee. I'm also a member of the Montana Prevention Certification Board and the Montana Alliance of Prevention. I received my bachelor's in social work and my master's in journalism from the University of Montana, and I also completed a second master's degree and my doctorate in prevention science from Washington State University. I am of a sonnet band of Wampanoag, African American, and European descent, and I was raised on the Flathead Indian Reservation in Montana, which is where I still live. And in my free time, I love to paint and be outdoors with my family and my 3 dogs. The learning objectives for this course are as follows. We hope by the end you'll have learned a little about the prevalence rates of common mental health issues in the United States. You will become familiar with the risk and protective factors for mental health. You will understand the relationship between mental health and substance use. You will explore mental health promotion and prevention strategies. We will also be talking about understanding the importance of cultural humility as it relates to providing prevention services. And lastly, you'll learn about the social determinants of mental health and how they impact equity and disparities. This course is divided into 4 sections. We'll start with an overview of mental illness in the United States. And secondly, we'll get into some of the symptoms of mental illness and the associated risk factors with a couple of more common mental illnesses. Then we'll start talking about the strategies for mental illness prevention and mental health promotion. And then lastly, we'll talk about equity and the social determinants of mental health. Okay, we're starting with an overview of mental illness in the United States, and we'll provide some definitions and some statistics. First of all, a definition of what is mental illness. So the American Psychiatric Association defines mental illness as referring collectively to all diagnosable mental disorders. So health conditions that involve significant changes in thinking, emotion, and or behavior, and that cause distress and or problems functioning in social, work, or family activities. And mental illnesses are chronic health conditions, meaning that they can last a long time and often don't go away completely. They may continue throughout a person's lifespan. All right, we have a pop quiz here at the beginning. What do you think, true or false, about 1 in 4 American adults have a mental illness? The answer may be surprising, but it is true. Mental illnesses are very common in the United States. In 2022, according to the National Survey on Drug Use and Health, almost 1 in 4 adults had a mental illness. And that is defined as any mental illness, which means a mental, behavioral or emotional disorder. Mental illnesses can range in their intensity and their impacts on people's lives. They can range from no impairment to maybe mild, moderate, and even severe impairment. Most people with mental illness are able to continue to function in their daily lives. However, about 5.5% of adults in 2022 also had a serious mental illness in the past year. So serious mental illnesses are defined as a mental, behavioral, or emotional disorder that results in serious functional impairment, meaning that it substantially interferes with life activities. Adolescents similarly face mental health challenges, with about 1 in 5 experiencing major depression in the past year, and a similar percentage reporting symptoms of anxiety. This figure from the National Institute of Mental Health shows the past year prevalence of any mental illness among U.S. adults, and it provides a deeper dive into the topic by disaggregating the data by gender, age, and race or ethnicity. So this is from 2021, and you can see that nearly 23% of all U.S. adults in that year met criteria for having any mental illness. This is the equivalent of 57.8 million adults ages 18 or older. And this is not including substance use disorders or developmental disorders. Any mental illness was more common among females than males, and young adults had the highest prevalence of mental illness compared to adults that were over age 26 and over age 50. The race and ethnicity headers get cut off a little bit in this graph, but from left to right, they're Hispanic, white, Black or African American, Native Hawaiian or other Pacific Islander, American Indian, Alaska Native, Asian American, and 2 or more races. So looking at race and ethnicity, adults who reported 2 or more races, so were multiracial, were most likely to report a mental illness. Nearly 35% of multiracial adults reported having a mental illness, followed by American Indian and Alaska Native adults at 26.6%. And this graphic provides some insight into anxiety and depression among adolescents, so ages 12 to 17. This info comes from the teen version of the National Health Interview Survey that collected data from youth respondents in both 2021 and 2022. So you can see again that there are some differences by gender, with females being more than twice as likely to report symptoms of anxiety and depression than their male counterparts. And in addition, adolescents who identify as LGBT plus reported substantially more anxiety and depression than their peers. The most common mental illnesses in the United States are anxiety disorders and depression, with just over 19% and 8% of the adult population having these conditions. In addition, some other mental illnesses that are more prevalent in the United States include post-traumatic stress disorder, bipolar disorder, borderline personality disorder, obsessive compulsive disorder, and schizophrenia. Mental illness and substance use disorders may occur together because there are common risk factors to both conditions. Both substance use disorders and other mental illnesses can run in families, meaning that certain genes might be a risk factor. In addition, there might be common environmental factors such as stress or trauma that put people at risk for substance use disorders and mental illness. Mental health issues can also contribute to substance use and be a risk factor for the development of a substance use disorder. For example, people with anxiety or depression or post-traumatic stress disorder may self-medicate with drugs or alcohol. And although some substances may feel like or even temporarily help with some symptoms of mental illness, they often make the symptoms worse over time. Furthermore, substance use can contribute to the development of other mental illnesses. Substance use can cause changes in brain structure and function that make a person more likely to develop a mental disorder. And research suggests that mental illness and substance use issues often interact to compound each other's impacts. So this Venn diagram from the Substance Abuse and Mental Health Services Administration, or SAMHSA, shows the prevalence of substance use disorder and any mental illness among U.S. adults. At the bottom, you can see that overall, 84.2 million adults aged 18 or older had either a mental illness or a substance use disorder in the past year. So that's nearly 1/3 of the adult population in the United States. On the left, the blue part of the circle represents 25 million people, or close to 10% of the adult population, that had a substance use disorder, but not a mental illness. On the right, in the yellow circle, are those that had a mental illness, but not a substance use disorder, and that's 37.7 million people, or about just under 15% of the adult population. And lastly, the green overlapping portion, you can see that 21.5 million adults, or 8.4% of United States adults, had a co-occurring mental illness and substance use disorder both. The researchers who conducted SAMHSA's National Survey of Drug Use and Health asked respondents questions about both their mental health and substance use. And here they compared the results from adolescents who had met clinical depression criteria in the past year and those that did not, and found that adolescents who reported meeting criteria for clinical depression were more likely to use some substances than their counterparts who did not have depression. So in 2022, adolescents aged 12 to 17 with past year episode of depression were more likely to have used illicit drugs, marijuana, and opioids in the past year. And as well, those adolescents with depression were more likely to be past month binge alcohol users, um, use tobacco products, or to vape nicotine. So we'll stop for a knowledge check. See, check in if you're listening. What are the two most common mental illnesses in the United States? Is it A, anxiety and PTSD, B, depression and schizophrenia, or C, anxiety and depression? So the correct answer is anxiety and depression. Okay, next we're going to dive into some of the symptoms and risk factors related to some of the more common mental illnesses in our population. Okay, first we'll talk about anxiety disorders, as they're the most common mental illness in the United States. So, occasional anxiety is a normal part of life. We all worry about things like money or health or family or relationship problems. But anxiety disorders involve more than just temporary worries or fear. For people with an anxiety disorder, the anxiety doesn't just go away, it can get worse over time. The symptoms can interfere with daily activities like jobs and schoolwork and relationships. There are several different types of anxiety disorders. Generalized anxiety disorder usually involves a persistent just feeling of anxiety or dread that can interfere with daily life. People with panic disorders have frequent and unexpected panic attacks. So, panic attacks are sudden periods of intense fear, discomfort, or the sense of losing control, even when there's not a clear danger or trigger. Social anxiety disorder is an intense, persistent fear of being watched and judged by others. For people with social anxiety, the fear of social situations might be so intense that they just avoid those environments entirely. A phobia is an intense fear of specific objects or situations. For instance, the fears of flying, heights, or certain animals like dogs or spiders. The fear people with phobias feel, however, is out of proportion to the actual danger caused by the particular situation or object. There are both genetic and environmental risk factors for anxiety, and the risk factors for each type of anxiety disorder vary. But some kind of general risk factors include those who are feel very shy or distressed and nervous in new situations when they were a child. They're more likely to develop an anxiety disorder. Uh, People who are exposed to stressful and negative life or environmental events can be a risk factor. And then lastly, a history of anxiety or other mental disorders in biological relatives, so in your family members, that can put you more at risk. So next, let's talk about depression. Depression is a common serious mood disorder, and note that it often co-occurs with anxiety or substance use disorder. Depression causes severe symptoms that affect how a person feels, thinks, and handles daily activities such as sleeping, eating, or working. And although we all may feel occasionally overwhelmed by life stressors, this is beyond just feeling sad or down in response to those challenges. To be classified as depression, these symptoms would last most of the day, nearly every day, for at least 2 weeks. The risk factors for depression can be genetic, biological, or psychological, and include a personal or family history of depression and major negative life changes, trauma, or stress. For example, the death of a loved one, or loss of a job, a breakup, bullying, or victimization. In addition, people who are more emotionally sensitive in general and those who experience childhood abuse or neglect are more likely to get depression, and females are more likely to develop depression than males. I'm including suicide in this presentation because it's a possible repercussion of mental illness. Research estimates up to 90% of people who have died by suicide have struggled with mental illness. Suicidal behavior is complex and there's no single cause. Stressful life events such as like the loss of a loved one or legal troubles or financial difficulties and interpersonal conflict or stressors like harassment, bullying, discrimination, or relationship troubles can all contribute to suicide risk, especially when they occur along with suicide risk factors. The main risk factors for suicide are depression and other mental disorders or substance use disorder. Depression in combination with substance use disorder is the most common diagnoses of suicide victims. Having a family history of mental disorder, substance use, or suicide can put you at increased risk. Having a personal history of suicide attempts also is a risk factor. Being exposed to violence in the home, including physical or sexual abuse, being in chronic pain, and the presence of firearms in the home are all risk factors for suicide. Men are more likely to die by suicide, but women are more likely to attempt to take their own life. Suicide is a big problem in Montana. The Montana Department of Public Health and Human Services issued a report in 2022 on suicide in our state. And unfortunately, we have some discouraging statistics around suicide. Montana has ranked in the top 5 for suicide rates in the nation for the past 30 years, and we're currently at the having the third highest rate of suicide in the country. The American Indian and Alaska Native population in Montana is disproportionately impacted by suicide and has the highest rates of suicide of any racial or ethnic group in Montana. And perhaps not surprisingly, firearms are the most common means of suicide in Montana. Lastly, one last statistic from that report is that the youth suicide rate is more than double the national rate for this age group. Montana's Office of Public Instruction administers the Montana Youth Risk Behavior Survey every other year. And in 2021, 41% of Montana high school students reported feelings of sadness or hopelessness for 2 weeks or more, so much so that they stopped doing some of their usual activities. And this is an indicator of depression and the highest rate since the Youth Risk Behavior Survey added this question in 1999. This number is elevated when you look at American Indian and Alaska Native youth on reservations or in urban areas, students with disabilities, and students in alternative schools. 21.7% of Montana high school students reported seriously considering attempting suicide in the past year, and over 10% reported actually attempting suicide. These numbers are substantially higher than national rates. So, knowledge check. True or false, Montana has one of the lowest suicide rates in the nation. And I hope you answered false. This was just a quick knowledge check to make sure you were still awake after all those statistics. Next, we're going to talk briefly about getting help after a mental illness diagnosis, and then we'll start into strategies for mental illness prevention and the promotion of mental health. So, only around half of Americans with mental illness receive treatment for it each year. And there's a few reasons for that. First of all, there's a lot of stigma around mental illness in our society, despite how common it is. For both adolescents and adults, the most common reason they reported for not receiving treatment for a mental illness was that they thought they should have been able to handle their mental health and their emotions or behavior on their own. That was almost 87% of adolescents reported that, and just under 3/4 of adults. So this pressure might be especially strong in a state like Montana that projects an image of rugged individualism. For adolescents, their second largest barrier was being worried about what other people would think or say if they got treatment. Close to 60% of them were worried about that. Access to care is another huge challenge for those who seek help. And there's a shortage of providers in most rural areas, and in Montana, we have also an underfunded system that's compounding the issue. For adults, the second most common reason for not seeking help is thinking that treatment would cost too much. And close to 60% of adults with a mental illness reported that as a barrier for getting help. So it's important to note that there are effective treatments for mental illness. People can and regularly do recover or find ways to cope with illness, challenges, crisis, and trauma. It may mean getting prescribed medications from a doctor, visiting with a professional counselor or psychologist, making changes to one's lifestyle, or participating in a support group. Anxiety and depression are generally treated with psychotherapy, medication, or both, and even the most severe cases can be treated. The earlier treatment begins, generally, the more effective it is. For those of us in the prevention field, our role is to provide prevention programs before people become unwell and to make referrals to mental health professionals when needed. About 50% of mental illnesses develop by the age of 14 and 75% by the age of 24. Since the prevention field attempts to intervene before problems begin, youth are a high priority population for mental health interventions. Next, we're going to talk about the causes of mental illness and start thinking about how prevention professionals might intervene. So, mental illness can have a wide range of causes. For most people, there's likely a complicated combination of factors, including genetic, biological, psychological, and environmental. At any one time, a diverse set of personal, family, situational, or societal factors combine to impact our mental health. Genetic related causes include our family history, as mental illness can run in the family. Our biology also impacts our mental health. We may develop chemical imbalances in the brain that can cause mental disorders. Psychological factors include cognitive, emotional, and attitudinal processes, meaning our personality traits, our thoughts, emotions, attitudes, and coping responses to life stressors can make us more likely to develop a mental health disorder. Our environmental factors include your life experiences. These can be adverse childhood experiences or ACEs and trauma. Those things that happen to you as a child can have an impact later in life, such as causing PTSD, panic disorder, depression, substance use, or suicidal thoughts. Stressful or negative life events like losing a loved one or being in an accident, those things can lead to, like, say, anxiety or depression, as can chronic stress, being under chronic stress. And that can be the result of dealing with stigma, racism, poverty, violence, and inequality. Substance use, as we discussed earlier, can change brain chemistry and function. For example, caffeine and cannabis can contribute to anxiety, and alcohol is a depressant. And then cannabis use is also a risk factor for psychosis. In terms of the environmental causes of mental illness, as the World Health Organization points out on the right, most people are resilient when it comes to their mental health, but those who are exposed to adverse circumstances, including poverty, violence, disability, and inequality, are at higher risk. The psychological and environmental factors are things that perhaps most interest prevention professionals, as they are the kind of factors that we can perhaps intervene on. When designing and implementing mental health interventions, prevention professionals often use a social ecological lens that looks something like this image. In the center is the child and their individual characteristics. And I like this particular version because it includes the child's cognitive, physical, social, spiritual, and emotional development. So their health and holistic development is surrounded and influenced by a number of different contexts that they exist within, including their family, their community, their greater culture and society, and then political systems. Each of these contexts hold risk and protective factors that shape a child's growth. So risk factors are conditions or characteristics that put an individual at increased risk of a negative health outcome. And protective factors are the conditions or characteristics that can protect an individual by moderating or alleviating the negative impact of the risk factors and help bring about positive health outcomes. Prevention as a field strives to reduce risk factors and strengthen protective factors in order to encourage desired health outcomes. Prevention interventions may target risk and protective factors at the individual, family, community, which includes school for children, cultural and societal, or policy and systems levels. So we can intervene at any of these levels or multiple. This slide provides some examples of protective factors that are related to mental health outcomes. There are many, and these are just a sample. Starting at the individual level, being able to manage and self regulate emotions, or being able to solve problems and have strong coping skills in dealing with life stressors. In the family context, the family providing structure, limits, rules, monitoring, and predictability are all protective for many mental and behavioral health outcomes. Having supportive relationships with family members is tremendously important. At the school and community level, feeling successful in school and achieving academically, as well as feeling engaged in the school and community, are both important for youth healthy development. And lastly, having physical and psychological safety, which is needed on many levels and could be impacted by family dynamics, school environment, and the systems and policies we have in place to protect and nurture children. So, those are all protective factors that are related to different mental health outcomes and some related mental health outcomes. Conversely, this slide provides examples of risk factors that are related to mental and behavioral health outcomes. Again, there are many more, and these are just some examples, but starting at the individual level, having poor social skills can negatively impact a child's interactions with their peers and community and diminish mental health. In the family context, having a dysfunctional family environment with lots of conflict or poor parenting skills can have lasting effects on a child's mental health. Experiencing academic failures in the school realm is a risk factor when it comes to mental health. Experiencing stressful or traumatic events like witnessing or being a victim of violence, losing a loved one, or living through a natural disaster can all have long term effects on mental health and even alter nervous system functions and future responses to stressful stimuli or situations. And lastly, it's important to understand that these risk factors and mental health issues influence each other. For instance, anxiety is a risk factor for depression, and both anxiety and depression are risk factors for substance use. Having multiple risk factors in a child's life can compound the risk for negative outcomes. However, the presence of protective factors can moderate the impact of the risk factors, and likewise, having multiple protective factors further reduces a child's risk for developing mental health issues. So, where does prevention come in? This diagram from SAMHSA depicts prevention as part of what they termed a behavioral health continuum of care. On the far left of this continuum is health promotion, which is strengths based strategies designed to promote well being and positive functioning. Next is prevention. Prevention programs are delivered prior to the onset of a disorder, and they're intended to prevent or reduce the risk of developing a behavioral health problem. And there are three types of prevention interventions. Universal, which is sometimes referred to as primary prevention, that involves interventions that are delivered to the general population, regardless of risk, before any sign of the target problem appears. An example of a universal prevention intervention would be a curriculum that every child in the school receives. Selective prevention interventions are strategies that target a subpopulation that is at risk. So there may have been some type of screening done or some condition met that makes a child eligible for an intervention. For instance, being eligible for some kind of services or resources because of socioeconomic status. Indicated prevention strategies target individuals that are exhibiting signs that they may be developing the problem. So this may be youth that are referred to a program because they are having behavioral issues. On the right half of the continuum are treatment and recovery. Treatment means services for people who are diagnosed with a mental health or substance use disorder, and recovery refers to services that support an individual with their long-term treatment and aftercare. The following are examples of evidence-based prevention programs for mental health. Evidence-based prevention programs are those that have been developed, tested, and found to be effective in improving mental or behavioral health outcomes. The state of Montana has a database on the Department of Public Health and Human Services website called the Evidence-Based Programs Dashboard. And you can use this dashboard to search for programs known to be effective on different outcomes. I ran a search for programs targeting depression and anxiety, and these are some examples of what came up. So under universal programs, so those that target the entire population, there were quite a few programs that fell under this category. You might have heard of the PACS Good Behavior Game, as it's been implemented in a number of Montana schools. It's an evidence-based universal prevention intervention that is delivered by teachers in a classroom setting. So the good behavior game, for example, is based on behavioral science, neuroscience, and cultural wisdom, and it provides strategies that help improve children's self-regulation. So these are approaches that they build into the daily school routine, such as ways to get the classroom's attention, transition to other tasks, and promote pro-social behavior. About halfway down the list of universal programs is a program that I'm certified instructor of, the Question, Persuade, Refer training for suicide prevention, or QPR. QPR is a short 1 to 1.5 hour program that's designed to teach folks the warning signs of a suicidal crisis and how to respond. So like CPR, QPR is designed to be taught to anyone with the belief that any of us can save a life. Under the selective programs, some examples of selective programs would be like the Big Brothers and Big Sisters of America program that matches adult volunteer mentors with an at-risk child. And Family Spirit is a home visiting program that's designed for Native American parents of young children. Under indicated, lastly, that an example of an indicated prevention program would be the Coping and Support Training, or CAST program. CAST is a school-based program for reducing the risk of adolescent suicide. Youth who are struggling with a depressed mood and or have had thoughts about suicide are referred to that intervention, and it goes through a curriculum in a small group. So just for your reference, the Evidence-Based Program Dashboard is a great resource to identify programs that may fit your community's needs, and the link is on the bottom of this slide. There's also an evidence-based policy dashboard if you're seeking policies that promote healthier outcomes for communities. Before we go any farther, I want to talk about practicing cultural humility in our role as prevention professionals. It may be tempting to think you are going to swoop in with this great prevention program and solve everyone's problems, but it doesn't work that way. You run the risk of implementing a program that does not resonate with the members of your community that you are trying to reach, or it doesn't address the right risk and protective factors and may even be offensive. So I recommend starting by involving your community in every step of the prevention process. Working with the community as partners respects the people we serve and empowers them to provide their own solutions to their prevention needs. They understand best the challenges, needs, and strengths of the community. Oftentimes, we are living and working with folks that are different than us. So make the effort to get to know your community and the populations you serve. Do your homework, read, use the Google, go to community events, and most of all, listen. Building relationships takes time, respect, and humility. We may have different assumptions, values, and expectations. When selecting prevention strategies, involving the community can help ensure that the prevention programs and activities are both appropriate and culturally relevant. Keep in mind that a prevention program can be evidence-based, but not tested, validated, or developed for a certain population. Involving the community in the prevention process helps us build our own capacity as prevention professionals to provide services that fit our community's needs, strengths, and culture, and that will produce the desired outcomes. Community buy-in also helps build sustainability. So don't forget the saying, nothing about us without us, and keep your community involved. All right, time for another knowledge check. Prevention programs are designed to A. Intervene before a problem begins, B. Serve an entire population or target an at-risk group, C. Reduce risk factors and promote protective factors, and D. All of the above. The correct answer is all of the above. Okay, now we're getting into our last section, which is on equity and the social determinants of mental health. You might have noticed throughout this presentation that there are disparities in mental health outcomes amongst different groups. This last section of the course is going to talk about why we see these inequitable outcomes amongst different populations and what we as prevention professionals can do about that. Here are some examples of differences we see between groups when it comes to mental health outcomes. Starting at the top in the blue box, we see that mental illness is higher among females than males. Following the circle clockwise in the next box, we see that young adults ages 18 to 25 have the highest prevalence of mental illness compared to middle-aged and older adults. When it comes to race and ethnicity, individuals who are multiracial and Native American report the highest rates of mental illness. And lastly, LGBTQ plus youth have higher rates of anxiety and depression than many of their peers. Why do you think that these disparities might exist? Well, let's talk about what puts people at risk of risk factors. First, let's explore socioeconomic status and race. Both socioeconomic status and race are closely tied to health outcomes. People's freedom and their ability to choose their lifestyle and the healthy option are severely diminished by poverty. So research has shown that the lower people are in the social status, the higher the rate of virtually every disease, condition, and risk factor. Institutional racism throughout the history of the United States, from slavery to redlining to the reservation system, have effectively put Black, Indigenous, and people of color at increased risk of living in poverty, which has negative impacts on mental and physical health. Secondly, we'll talk about social environments. People are social animals, and their social environments have profound effects on their well-being. Where you live, your community or neighborhood greatly influences the resources and opportunities you have available to you, as well as the amount of crime and environmental hazard you are exposed to. As we talked about before, the health of your family environment, the quality of parenting, the amount of conflict and violence a child is exposed to, their parents' mental health and substance use, and the socioeconomic status of the family all have huge impacts on the number of risk factors a child is exposed to. I would also purport that the socioeconomic status of the family can either alleviate or put additional stressors on the parents that can impact all of these family risk factors. The peer, social, and school environments, and for adults, this includes the workplace, can also be influential at the amount of risk in a person's life. What are an individual's peer and social relationships like? Are they a source of stress and conflict, or acceptance, support, and belonging? Healthy social environments provide both safety and opportunities. Research has found that consistently across all of these environments, environments that threaten personal safety or limit your ability to develop social ties and support, or are marked by conflict, violence, or abuse, are related to a number of adverse health outcomes. This may be starting to sound familiar to you if you have heard of the social determinants of health. The social determinants of health are social conditions that predispose people and groups to poor mental and physical health. They increase the risk for many mental and physical illnesses and cause folks to have poorer outcomes of these illnesses when they occur. Doctors Michael Compton and Ruth Shim, who are psychiatrists and public health researchers, wrote multiple terrific papers on what they term the social determinants of mental health. These include racial discrimination and social exclusion, adverse early life experiences, poor education, unemployment, underemployment, and job insecurity, poverty, income inequality, and neighborhood deprivation, poor access to sufficient healthy food, poor housing quality and housing instability, adverse features of the built environment, and poor access to healthcare. Here, Compton and Shim model how the social determinants of health and mental health operate. At the bottom, you have public policies and social norms that dictate how opportunity is distributed in an unequal manner. The unequal distribution of opportunity drives the social determinants of mental health. Those are there in gray. They create stress and constrict options, leading to poor choices and risky behaviors that lead to social, environmental, and behavioral risk factors. You can see on the left that health policy and the healthcare system also play into it. And on the right, Compton and Shim hypothesize that the social determinants of health and stress in the environment also interact with genetics and issues that are commonly perceived as biological. All of this combines to increase the risk for a number of mental illnesses, other disease, and morbidity. Understanding the social determinants of health and mental health help us further understand what put people at risk of risks or provide us with protection. Understanding the context of the people we serve helps guide effective interventions. Without understanding the context, interventions will fail more often because they will target behaviors resistant to change. For example, teaching coping skills should not be expected to solve the chronic stress that's baked into society. So understanding the social determinants of mental health necessitates the interventions that are at the societal, policy, and systems level. The effects of the social determinants of mental health can be altered through individual and family level interventions and programs, but as well as policy and systems change. Although we must intervene at all levels, the deeper we go into the roots of problems, the greater the overall impact for the population. Prevention professionals must be present in the discourse on social injustice. We also must be active in advocating for changes in social norms and public policies that are needed to address the inequality that is associated with negative mental health outcomes. One last knowledge check to make sure you stayed with me for this entire course. True or false, advocating for social change is part of prevention? And the answer, of course, is true. So thanks for taking this short course on mental health and prevention, and that you've reached the end. We have a few additional pages on references that I'll click through.